Good morning and welcome to the San Francisco Interfaith Council online briefing for community and faith partners. In today's program, we discuss what the faith community needs to know in the post-recovery phase of COVID-19. Our program is featuring Dr. Peter Chin Hong of the University of California, San Francisco. A special thanks, this San Francisco Interfaith Council online briefing is supported by a grant from the Center at Sierra Health Foundation. Thank you. The important and ongoing work of the San Francisco Interfaith Council would not be possible without generous funding from congregations, corporations, faith-based social service agencies, foundations, judicatories, and supporters like you. Help us spread the word. Visit sfinterfaithcouncil.org to learn about SFIC programming and how to become a supporter. Follow SFIC on Facebook and Twitter, and subscribe to SFIC's YouTube channel to watch all of our virtual events. A bit of housekeeping. This program is being recorded. For audio and video, all participants are muted and without video to minimize distraction. For chat, submit a question or comment by selecting the chat button at the bottom of your screen and sending a message to Q&A. Questions will be forwarded to the host and answered time permitting. For closed captions, select the live transcript button at the bottom of your screen and click Enable Live Transcription. And at this time, I'd like to hand the floor over to the Executive Director of the San Francisco Interfaith Council, Michael Pappas. Michael, the floor is yours.
Thank you, Trey. Good morning. I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this week's online briefing for community and faith partners. This particular segment is generously underwritten by a grant from the Center at the Sierra Health Foundation. This week's briefing will shine a light on the post-recovery phase of COVID-19. Featured presenter, UCSF Associate Dean for Regional Campuses and infectious disease treatment specialist, Dr. Peter Chin Hong, will offer important insights on COVID-related therapeutics, changes in the virus, advances in research, and improvements in vaccine efficacy. He will cover current guidance for faith institutions, best practices for faith leaders in communicating on COVID to their constituents, faith-based community health information, and other related topics. As we do at the beginning of all of these programs, allow me at this time to read our interfaith statement. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we're invited to offer prayer in this setting, it should be offered according to the tradition with which we identify. If we're invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other, that we might better understand the multiplicity of faith traditions in our city and in our world. At this time, it gives me a great pleasure to welcome back SFIC board member, but also associate pastor at Third Baptist Church, and San Francisco African American Faith-Based Coalition executive director and assistant professional researcher at UCSF Department of Family and Community Medicine, Reverend Dr. Jonathan Butler. Dr. Butler has been a regular on this program, and this morning he will ground us in a reflective moment. Dr. Butler, it's great to see you, friend.
Thank you, Director Pappas, and good morning to everyone. In the heart of San Francisco, a rich tapestry of souls departed, leaving behind legacies woven with threads of compassion, courage, and love. The Reverend Cecil Williams and Imam Abu Nadir Al-Amin, two towering figures in the community, stood as beacons of hope and unity, their presence shaping the lives of so many. Reverend Cecil was known for his boundless empathy and tireless advocacy for the marginalized, especially those who experience homelessness in the LGBTQIA community. His ministry transcended boundaries, embracing all with a message of inclusion and acceptance. Imam Al-Amin, a leader in faith and interfaith dialogue, a man of honor, integrity, and service, will always be remembered as the foundation and pillar of San Francisco's diverse Muslim community. His professional and community contributions has impacted this and many more generations to come. Both men have had long tenures, and their passing leaves a void in the fabric of our city and this nation, yet their impact remains etched in the hearts of those they touched, including myself. And so as we mourn their loss, we are reminded of the pressing challenges that we face today. Homelessness persists, health disparities are widening, injustices continue to plague our communities. And in times like these, I always like to return to the words of the Bible for guidance. And it is that great physician Luke, in Luke chapter 4, verses 18 and 19, where he writes Jesus's words, who proclaims the passage of Isaiah, "The Spirit of the Lord is on me, because that Spirit has anointed me to proclaim good news to the poor, sent me to proclaim freedom for the prisoners and recovery of sight for the blind, to set the oppressed free, and to proclaim the year of the Lord's favor." Friends, we are called to carry on the work of these exemplary leaders by collectively striving to right the wrongs of our city. And it begins with understanding and empathy, as we demonstrated in the Truth, Justice, and Reconciliation pilgrimage sponsored by Glide Center for Social Justice. Dr. Peter Chin Hong, myself, and UCSF colleagues, along with Glide staff and community partners, journeyed through the historic sites of Alabama, including 16th Street Baptist Church, the Birmingham Jail, Tuskegee University, the Evan Pettus Bridge, and underscored the legacy of racism and the importance of reconciliation. And in our pursuit for justice and equality, we must engage in dialogue, bridge divides, and extend compassion to all. It is through unity and solidarity that we can address the systemic issues that perpetuate suffering and inequity. Just as Cecil Williams and Iman Amin dedicated their lives to lifting up the marginalized, we too are called to continue their legacy by advocating for a just and equitable society. Walking in the footsteps of these luminaries, we are reminded of the transformative power of compassion and unity. Their teachings resonate through the echoes of history, urging us to stand up against oppression, to stand by those in need, and to sow the seeds of peace and reconciliation. And so when honoring Cecil Williams and Iman El-Amin, we commit ourselves to carrying forward their mission of love and justice. Their spirits live in the collective effort to build a more equitable and inclusive society where every individual is valued, every voice is heard, and every soul is embraced. And so may we draw inspiration from their legacies. May their light guide us to the pursuit of a brighter and more compassionate future. And in their honor, I would like to honor them today. Let us continue their work with renewed resolve and unwavering dedication, knowing that unity and love, through that, we can truly make a difference. Thank you.
Amen. And thank you, Dr. Butler, for grounding us in this reflective moment, and for your continued good works throughout our city and on behalf of our communities of faith. You are a blessing to us all. Speaking of blessings, we are very blessed to have as our featured presenter today from the University of California, San Francisco, Dr. Peter Chin Hong, who is the Associate Dean for Regional Campuses. He's a medical educator who specializes in treating infectious diseases, particularly infections that develop in patients who have suppressed immune systems. He directs the Immunocompromised Host Infectious Disease Program at UCSF. The program we have today is an important one, because I know that there are many people who believe that COVID is over, and if not only they believe it, they want it to be over, and yet it still persists. Dr. Chin Hong, we are grateful because we know that during the pandemic, we relied on the good counsel of medical professionals as yourself in order to create policies to protect those who are entrusted to our care. And I was thinking, as I was considering my introduction of you, I was remembering days as a parish priest, a Greek Orthodox parish priest, and I would go to bedsides in hospitals. And in addition to praying for that great miracle, we would also pray for the hands of those who are ministering so that God's glory may be revealed through them. We look upon our medical professionals as those hands of God at work. And so we are grateful for all that you do. And I'm going to hand the floor over to you because I think what you have to say today on this subject will be helpful in the continuing care for those entrusted to those most vulnerable who find their homes at our communities of faith. Welcome.
Thanks so much, Director Pappas, and thanks to Dr. Butler for such a beautiful reflection and words, and thanks to Trey also and the San Francisco Interfaith Council. So let me share screen right now. So what I'm going to do in the next few minutes is really level set, see where we are right now, and then at the end, see where we're going, and give some reflections, not just on COVID, but a few reflections on some other developments that might be related in terms of infectious diseases. So I'm just going to start off with where we are in terms of disease right now. So even though many people think, we're over this, nobody wants to think about the last 4 years. It's almost like you get PTSD when you think about it. There's still high levels of virus activity in some parts of the country, very much lower than we were even just a few months ago. But you can see in some states, it's still at the red level, and even in New Mexico here. So, I think what it really says is that it's always an evolving picture. And even though there aren't as many people going to the hospital right now, they still are. In fact, I'm in the hospital taking care of patients this week. And, I'm taking care of 2 very sick individuals who have COVID still. They are at risk, very immune compromised, but didn't get the most recent vaccine, even though they've gotten vaccines before. So it really speaks about continuing to monitor the risk carefully among us. So in terms of COVID itself, we have very much fewer hospitalizations than we did. You can see in February of 2022, that's kind of where our peak of hospitalizations were. And now we're down to a few thousand a week. And in fact, there's more influenza hospitalizations and emergency room visits than COVID right now, which is really attesting to the population immunity that we have. So a question for the audience, and you can just put it in chat, or just reflect on your own, is how many COVID deaths did we have in 2023? That's all of last year. And the reason why I bring that up is that even in 2023, people were thinking that we were over the worst of it, which we were, but it didn't mean that it wasn't still a threat. And to give you some perspective about numbers, every year, even before the pandemic, we probably get about somewhere like 35,000 deaths a year from influenza. So 2023, I just want you to think about how many deaths do you think we had in COVID in the United States? And so the answer is 745 COVID deaths. So very much still above our normal influenza rate, which has kind of been our standard. Although one would say that it should be close to the 0 given all the tools that we have, like the tools we have for COVID. So in terms of what we're seeing now with influenza, we don't have final numbers yet, but again, probably a little bit lower than COVID, but still very high, and one would say very unacceptable, with as many as 56 million flu illnesses, translating into medical visits, hospitalizations, and unfortunately deaths. So I think moving forward, we'll always be comparing flu to COVID. And as Director Pappas said, COVID isn't going anywhere. And if you think about that, that's 75,000 more people whose lives we could have cherished otherwise. with a new threat. So where are we in terms of variants? So as you know, COVID has evolved over the time that we've known it. It's continued to shapeshift. And right now we're still in Omicron. Omicron has really evolved to be something that's very transmissible. And it's not that it's less scary looking in the lab. It's more that we're stronger. The soil in which the virus is landing is much more inhospitable. So as these virus variants get created and made, because it's kind of natural for the virus to do that over time, we are getting stronger in general, but not everyone is strong. And I think that's probably one of the biggest take-home messages for today. So right now we have mainly JN1, which is a variant of Omicron, and it's all pretty much covered by the latest version of the vaccine. So that's the biggest take-home point from this slide. So this is me when I'm crossing the street and a car acts like they're not going to stop, but it's also my expression when people come to me with a lot of far out ideas about COVID. I think it's really important to acknowledge that and to be curious. So the way I communicate with people is not necessarily to dismiss them, but to like you do when people come to you for concerns that might be a little bit off base and not scientific. You listen their spectrum of beliefs, acknowledge it, and have a conversation about it. So we talked about where we were in terms of where the disease was. We talked about what variants were circulating right now. I'll just give you a few updates on treatment right now. So the way we treat COVID is a combination of two things. We try to shut down the virus factory, which is more upstream, so you create less virus, and that's after you get infected, and that's things like remdesivir and Paxlovid. They really target the upstream creation of viruses, of more viruses. But we also, for sick people, try to tackle inflammation. In fact, before we had antivirals at the beginning of the pandemic, we mainly had things that we can do to tackle inflammation, which is when the immune system gets super angry because it sees the virus. And that's really the cause of a lot of people's downfall. And that's what gets people really, really sick. So it's a combination of two things that we do. We try to beat down the virus by shutting down the virus creating factory. And these are antiviral medications like Paxlovid. But for sick people, we also try to make the immune system less angry. And that's by giving medicines that suppress the immune system a little bit, or something like steroids, for example. So where are we in 2024 in terms of thinking about treating people in the outpatient setting with COVID? It's really a matter of shoulds and coulds, and I think a lot of the confusion is because these recommendations have kind of shifted over time as to who should get antiviral medications. But from my perspective, people who should get antiviral medications are for sure those who are over 65, especially if you've not gotten the new COVID vaccine. And again, like I mentioned, I'm taking care of two people right now who are very ill, still with COVID, even though it's April, and they are at risk and didn't get the most recent vaccine, even though they've gotten maybe several at the beginning of the pandemic. The other group, so in the United States, about 58% of those over 65 have not received the latest COVID vaccine. The other group that should get the antivirals if you are infected are those who are very immune compromised. So those are people who have just received a transplant. So your body's immune system is the weakest then, because the reason why it's the weakest is because we don't want your body to reject the new organs. So we give medicines to suppress that immune system. So those people and people who receive medicines that target antibodies, those are people who have some kinds of malignancies. They're at most at risk of getting really ill. So they should be prioritized for Paxlovid and early therapy. So if you have congregants who fall into these categories, I think engaging with them still right now about getting a vaccine if they haven't gotten it since the new one came out. It's a pretty simple rule. The new vaccine in the fall of last year, did you get it, yes or no? And if you didn't, particularly if you're at risk, please go ahead and get it. And, in terms of these medicines, like Paxlovid, it's really available to be prescribed for anyone over the age of 12, weighing at least 88 pounds. But the sort of intermediate category is pretty much everyone over the age of 50. Although most people, if you've gotten the most recent vaccine, you're not going to be at risk for getting seriously ill. So that's why the should category is one that should be etched in our brain. So whatever you do, don't call it Paxlovid rebound. People talk about rebound when you get Paxlovid, but we've started calling it COVID rebound because you can get rebound, which is, the virus goes down and then it comes back up again. Even if you didn't take Paxlovid, as we understood from recent studies. So just to remind you about Paxlovid, it's 3 pills twice daily for 5 days. It doesn't depend on what the spike protein is in the COVID virus, which changes, and that's why our immune system can't always recognize it. And that's why we need vaccines, particularly if you're at risk. But things like Paxlovid it doesn't matter what variant you have, because it targets the creation of the virus before these spike proteins are made. So kind of more upstream. So it will continue to work regardless of what variants we have. You have to take it within 5 days after getting infected or knowing that you're infected, because early treatment is really the most effective. And you have to watch out for drug interactions. It is FDA approved as of last year. So, I think it's pretty straightforward at this point to get. In terms of how well it works, we know even from most recent studies that the efficacy is 90% in those who haven't been vaccinated and at risk in preventing serious disease. So quite potent, even if somebody didn't get around to getting the vaccine. So the people I'm taking care of this week, not only didn't they get vaccinated, but they didn't get Paxlovid either, because Paxlovid is kind of a get out of jail card, even if you didn't manage to get vaccinated and you're at high risk. In terms of younger people taking Paxlovid, the studies are more mixed, and probably as a population, those under 50 don't benefit as much from taking Paxlovid. But if somebody is seriously ill, and certainly all immune compromised individuals, regardless of age, would benefit. But healthy people under the age of 50 may not benefit quite as much. But there's very little harm in taking Paxlovid if people aren't sure. I think coming down the pipeline, there are going to be new antivirals that will be easier to take that don't have drug interactions. This is one example of one that's currently being evaluated by the US FDA. It's called Shokova, and it's already approved in Japan and some other countries. It's a similar situation of taking it early for 5 days, and studies have shown that you get 1 day decrease in symptoms, which is kind of what you get with Tamiflu for influenza. And right now they're collecting hospitalization data, but again, if there are no drug interactions, it's well tolerated. It's probably going to be a viable alternative to Paxlovid by the end of this year. I thought one way to think about how you talk to congregants about Paxlovid or taking early therapy is around answering some myths or misunderstandings that people might have. The first is that, well, maybe I don't need to take Paxlovid because the population immunity is so high that, I'm not going to get really ill. As I mentioned, there's still a few hundred people who are dying every week in the United States, even at this lowest point. And it's interesting that about 95% of these have not received the new COVID vaccine. Most of the individuals are over the age of 75. or immune compromised, very immune compromised. And I would say that not only didn't they get the most recent vaccine, but they also didn't get prescribed early antiviral therapy like Paxlovid. Because again, even if you didn't get the vaccine, you can still stave off hospitalization. You can still stave off death by getting access to these early therapies. So another myth that I'm hearing commonly is that people have a high chance of rebound if they take Paxlovid. So I mentioned that we call it COVID rebound now, not Paxlovid rebound, because studies have shown that even if you don't take Paxlovid, as much as 20% of people would have rebound. When it does occur, rebound is brief and mild, doesn't cause people to go to the hospital. So again, the balance is really in taking some of these early antiviral medicines, particularly in those who are older, didn't get the most recent shot, or very immune compromised. Another myth that people might say is, well, I might be older, I didn't get the recent shot, but my symptoms are so mild, so maybe it doesn't matter if I take Paxlovid or not. But just remember that in the beginning, the symptoms can be quite mild, up to 7 days, and the people who get very sick before you fall off the proverbial cliff in COVID symptoms. And if you remember President Trump, when he was ill, in the beginning, everyone was worried because, that early period is almost like the honeymoon period in COVID, if you're going to get sick, and then you turn around in a negative way after day 7 or so. So knowing that your symptoms are mild, if you're at risk, isn't always the best arbiter of whether or not you're going to turn up seriously ill. And also, I think another barrier might be drug-drug interaction. So I always tell people to speak to your primary care provider about the other drugs you're taking, to kind of come up with a Paxlovid plan in case you need to take this medicine if you got ill. I think another myth that even many providers have is that Paxlovid is still easy to get. It might be easy to get at Walgreens or CVS, but you may be given a big copay or full cost of price because people might still be getting used to Paxlovid getting on the free market. So the cost is probably, if you had to pay, something like $1,300 a course. So the most important thing is to arm people with the knowledge that nobody should be paying that. Most people shouldn't be paying anything. But there is this program called Paxess, Paxess, that people can look up or Google. It takes like 2 or 3 minutes to fill out. They don't ask about residency status or citizenship status or insurance or anything. And you can get it instantly approved for very low cost or free. So I think that's really important pearl of information to give people. So the bottom line, if you're at risk or your congregant is at risk, they're older than 65, particularly if they didn't get a recent vaccine and they got infected with COVID, the first thing you have to diagnose it, which is also another barrier, but really should think about getting Paxlovid. If you can't get Paxlovid because of drug interactions, there are also other options that we have, like remdesivir, but it needs to be given 3 consecutive days IV, can be given in an outpatient setting, or molnupiravir, which is another not as effective pill, but it can sometimes still decrease the risk of individuals. If immune compromised, we can sometimes give convalescent plasma as well. This is the antibodies from people who've recovered in the community, giving it back to people who don't have an immune system, and that can help the virus as well. When to treat, earlier the better. Who to treat, the should, as I mentioned, are those over 65 and never received the latest COVID shot. But anybody over 65 in general should sort of be the priority list for the should category. And then know about this Paxess program that really takes 1 to 2 minutes to enter the information, but you need a prescription first so that and many people still don't know about this, even providers. So it's important to come armed with all of this information. So where are we in terms of prevention right now? So we talked about where we are in terms of disease, the variant circulating, the treatment options for early disease, and how we treat COVID in 2024. And now I'll turn my attention to prevention. So prevention is better than cure, and there are two main kinds of vaccines now. It's important to know that it's not all mRNA vaccines like Pfizer and Moderna, but there's Novavax approved with a new booster as well. And the reason why that's important is because people might have had terrible reactions, even though not life-threatening, to an mRNA shot. And the Novavax vaccine is a more traditional vaccine. It's a very good alternative, even though there are a lot more mRNA shots on the market. The mRNA shot works by giving the body the message to make bits of the virus, spike proteins, and then the body develops antibodies or fighting cells against it. So, and these kind of circulate around. So if you get infected with the real deal, the antibodies that you develop or the fighting cells, like Navy SEALs, will come and swoop in and neutralize those viruses before they can make more of itself. In the Novavax vaccine, you chop up bits of the spike protein and you inject it into people. So it's a very different way. It's not the message, but it's just pieces of the real deal spike protein, and then body sees it and makes the same fighting cells or antibodies against it. So the new shot that we have right now is approved in the fall of last year. There's just one. So again, very simple. You don't have to think about how many or like which type of vaccine to ask for. And it's based on an Omicron type, which is very similar to what's circulating right now. So it's, a very effective vaccine. There are three companies that, as mentioned, the priority group is those who are 65 and older, because that's where we're still seeing deaths, or those who are immune compromised. And for kids, it's offered to everybody. For kids, they may need more than one shot depending on how young they are. And the reason for that is that people who've never been exposed to COVID before just need a lot of priming of the immune system to develop a robust immune response. So when the real virus comes, those cells will be, enough of those cells will be around to neutralize the virus. And like I mentioned, it works well against all circulating variants like JN1. But what's really disappointing and what kind of keeps me up at night is that the vaccination rates in the United States for the current vaccine, they're very, very low. Only 22.6% of adults, 13.5% of kids, and most concerningly, 42.4% of those over 65. Those are the people I'm still seeing in the hospital, sick with COVID. There's also the ability to get another booster for those who are over 65. But right now we have very generally low virus in the community. So, you might want to, if you're older than 65 and you've already received the COVID shot this year, you might want to wait until the virus comes back up before getting a reminder or a booster. But you're able to get it, particularly if you're traveling abroad and there's a lot of COVID somewhere else, or you're going to event and you're worried about it, and it's been more than 6 months, for example, since your last shot. You could get it from the FDA if you're over 65. If you're very immune compromised, you can even get it every 2 months if you wanted to, but speak to your clinician about it. I would say that the most important thing is just to get one. Just make it very simple. And the reason why it's important for people to get at least one is because antibodies decline in people over time, and it declines the fastest in those over 65. And that's why that's really the priority group. For the vaccine, that's the priority group for early therapy like Paxlovid. And the majority of those hospitalized and dying right now are over 65 and who didn't get the most recent shot, even if they got a lot of shots at the beginning of the pandemic. So the priority is really getting at least one shot for everyone. And no need to get a zillion shots. There's actually somebody in Germany who got 217 COVID vaccines. I don't know how he got in Germany, but scientists looked at his immune system and there wasn't anything that went awry. But of course, getting at least one is just as good as getting 217 shots. In terms of new developments, for people who can't make antibodies or the fighting cells, there is a solution right now, which is a long-acting monoclonal antibody. These were taken off the market in January of last year because the new variants had evolved so much and the spike protein had changed. So the antibodies, these are like factory-made antibodies. They weren't really fitting into the new shape of the spike protein as well. So they were pulled off the market. But then based on the new variants now, there's a new long-acting monoclonal antibody. And what it means is that you make that, if you can't make antibodies on your own, you can get a factory to make a bunch of antibodies and give it to you. So it's like if you made it your own in yourself, so it has the same protection, but it lasts about 6 months. So it's people whose antibody cells are shut down because of cancer or chemotherapy, or for example, Colin Powell, who died, had a disease called multiple myeloma. And that disease, all of his cells that usually make antibodies are diseased. So you could have given Colin Powell 1 million vaccines, he wouldn't have been able to respond. So in that case, if Colin Powell were alive today, we could have given him something like a long-acting monoclonal antibody, which are antibodies pre-made in a factory because he couldn't make it. And so that if Colin Powell got infected, these antibodies would be around and ready to fight. So that's available for people who are very, very immune compromised. It's given by IV. It takes an hour. Most of it is covered by insurance, but the cost price is, again, like many of these things, very high if you just look at the on face value. So this is not what you should do to use to protect yourself. And a coffee filter might sound like a cough protection, but it's not. In terms of consequences, and I'm now moving to the fact that we haven't really taken stock of the last 4 years. Nobody wants to talk about it, but we've had more than 1 million Americans who've died. Haven't honored these people in a substantive way. There's no memorial. So I think we really need to do that before moving on. I think many people still have a lot of trauma. Many people have lost so much. So I think in terms of working through that, this community, your community, our community will have a big part to play in the next few years. So what are some of these consequences? A lot of these consequences, I think, were because early on, people were very hesitant about getting vaccines. I think because of community activism, we were able to get all populations equally vaccinated in the Bay Area. But again, we have to keep up the fight. And history is against us. So I spoke to Greg Liggins, who's one of the KTVU news anchors and reporters, about some of his perspectives on why it may be difficult to reach all populations without continued work.
One thing I learned during the pandemic as it relates to minority communities is this prevalence of vaccine hesitancy. I saw this across age, gender, even to a certain degree, income lines. I think there are at least 2 reasons behind that. One would be the historical wrongs done to some minority communities. I'm referring, of course, to things like the Tuskegee experiment that people heard about and they just ran with that information. And then also the inconsistent and oftentimes contradictory messaging coming to us on both a national and local level. I'm not necessarily talking about the vaccine itself, but things like mask wearing, what you could and couldn't do indoors and outdoors. That messaging was just very inconsistent and really confused a lot of people.
So, we're not out of the woods yet. We still have, as I mentioned, a lot of legacy to deal with from COVID, a lot of fallout from COVID to deal with. One big fallout that we're still dealing with, which is affecting millions of Americans, is long COVID, or the chronic consequences of some people getting infected. The good news is that new long COVID is going down over time. Because the reason you get long COVID is you get infected, your body sees a lot of virus. Probably some of that virus gets archived or hide out in some parts of your body. So your immune system continues to be agitated. And it's the agitation of the immune system that causes the symptoms of long COVID, which is more than 200 symptoms. And now in most recent studies, they found that in some people, this virus can persist for more than 16 months. So, if you have, tools that can kick the virus out as soon as you get infected, you lower the risk of long COVID. And that's why vaccination is so potent, because the vaccination leads to the immune cells, or the fighting cells, that kick the virus out as soon as it gets in. So the virus doesn't stick around long enough to agitate the immune system and therefore get long COVID. If you take Paxlovid, it, again, kills the virus when it gets in, even if you didn't get vaccinated. And because the virus sticks around a little bit less, you have lower chances of agitating the body to get long COVID symptoms. So that's the reason why we're really promoting some of these tools. But nevertheless, there are people already who have these chronic symptoms. I'm sure there are people you know of who have it in your congregations. It's important to be empathic as you are. And I think early on in medicine, with many of these chronic conditions, patients were dismissed. But I think people are more aware of this. The problem is there's no test for long COVID. There's no blood test for long COVID. So we really have to go on people's symptoms. And that could be very unsatisfying. And it's leading to not as much progress in making medicines that can treat long COVID. We're really still at the early phases of understanding what it is. So therefore, prevention of it is better than trying to deal with the consequences of these chronic conditions once you have it. I think another legacy, of course, that we have to deal with is death. 1.1 million US deaths, 7 million global deaths, and it's estimated up to 30 million global deaths, because not everybody had diagnostic tools to link the death to COVID or tests in the beginning. But the way that people came up with a $30 million number, and probably millions in the US as well, is that you look at what you expect in terms of deaths, and you look at excess deaths, so the amount of deaths over the expected deaths, and that's how people might come to that number that's higher than the official death count. And if you compare it to the flu pandemic in 1918, it's not too much different, with about 20 to 50 million people dying over the flu pandemic of 1918. Of course, there were fewer people then, but my point is that we have a huge burden and a legacy to deal with. If you look at the HIV and AIDS pandemic, it's about 40 million people dying so far, but that's 40 million people dying over, several decades. So again, very different from this acute loss that we've had over the last 4 years. And when you look at where people are dying, again, you can probably impute that much of this has to do with politics of the state, and the way in which, COVID prevention has become a political issue. So Mississippi, Arizona, Alabama, New Jersey, and West Virginia. And when you look at California and where deaths have really peaked in the darker numbers, you can see that, the Bay Area, is probably one of the best places to be in during the pandemic. And I feel very fortunate and blessed to be here. But in places where there, people weren't as protected, Imperial County, San Bernardino, Los Angeles, and in Central Valley, Tulare and Madera, that those were areas that really bore the brunt of the deaths in California. Southern California is more mixed politically, so I think the ability of political leaders to embrace some of these scientific, advances really directly led, we believe, to the way in which populations were protected. And the United States as a whole, as you know, didn't do very well compared to other developed countries. During the pandemic in general, we had the highest number of deaths per 100,000 compared to other developed countries. And even you would say, well, maybe that's because that was the previous administration, and then with the new administration, we did better. But when you look at Omicron, we actually, the rest of the world distanced itself even more in having fewer deaths than we did. And that's because, it's very multifactorial. It's structural racism, access, but also politics and divisiveness that even got worse as the pandemic progressed, despite who was, the executive leader of the country. We focus on medical, traditional medical topics when we talk about COVID, like heart disease or diabetes, but mental health has also had a big fallout from the pandemic, as you very well know. The emergency room visits for mental health nearly doubled, even as the pandemic was starting, for children, especially adolescents, with a 5 times increase with suicide symptoms. The visits for mental health increased dramatically, despite the total number of emergency department visits remaining relatively stable. And why is that so? Because we have an unmet outpatient mental health need as a crisis because of COVID and people not being able to access it as much as possible, and social media that can lead to bullying, particularly in this population. And as the American Academy of Pediatrics says, this is really a national emergency. We have an epidemic of loneliness. This really even made it to Surgeon General report, where 1 in 2 adults report loneliness. And this was, again, accentuated during COVID-19. I know people still who are afraid of going out of their household, even today, with lower amounts of COVID. I think it's up to us to educate people that they don't need to be afraid. We have vaccines, which are very good. I'm not seeing people, and the data of the country are not seeing people who are vaccinated who are ending up very sick right now. People are unvaccinated. We have Paxlovid, even if people didn't become vaccinated. So it's really important to not have people continue to wall themselves off at home, isolated. We know that lack of social connection and loneliness is not just a mental health issue, it's also associated with higher risk of heart disease, stroke, anxiety, depression, dementia, and premature death. And as the Surgeon General said in his report, put simply, this social disconnection increases the risk for premature death to the same level as smoking up to 15 cigarettes a day. So what he advocated for was more parks, libraries, public transportation, family leave, and research into this topic. In the UK, there's a whole minister for loneliness. So I think this is really becoming seen as by political administrations as being something that could really impact people's health, physical and mental. And we've learned from some research that even weaker ties can be important for happiness. You don't really need to have everyone as your best friend and your family member to really be your network, as you know. It could be people you meet at the dog park, the bank teller, the regular waiter. These casual relationships might be weak ties, but they're also part of the key to well-being. But one of the legacies that particularly struck home hard for me was all the hate that we saw, particularly towards the second part of the last 4 years. So I talked to Betty Yu, who's a reporter for CBS in San Francisco, about her perspective on hate during the pandemic, particularly against Asian Americans.
Hi, I'm Betty Yu, and I'm a reporter with KPIX5 CBS San Francisco. And I spent the better part of the pandemic covering COVID and all the developments related to the virus, and also the string of high-profile attacks against Asian Americans in our community, particularly against the most vulnerable, the elderly. So We had COVID, which we had to be very careful about, and we also, as Asian Americans, had to watch our backs in our own communities. When I look back and I think about that time, what was most encouraging is being able to see our community galvanized in ways that I had never seen before. We supported one another, we spoke out, and this is something that we traditionally did not see a lot of Asians doing. So when I look back at that time and I think about all the activism that I witnessed, whether it was through speaking up, donating, marching in the streets, just sharing stories through social media, it gives me hope that when we band together, we can turn this kind of trauma and pain that we all experience as a community into strength and power.
So well said by Betty, and banding together, I think, is one of the strategies we continue to need to celebrate moving forward, because this is not going to be the last pandemic that we will see, even in our lifetime. Again, and there are warning symptoms already emerging. So I mentioned that COVID is not going to go anyway. We've had more than 75,000 deaths last year, and it was in year 4 already of the pandemic. So people think that it will probably settle down, at least in the next few years, to somewhere around that number. Hopefully it will be less if more people who are vulnerable get vaccines. But again, it's probably going to settle down to a vaccine once a year with the flu shot and with the RSV vaccine for people who are eligible for it. It will probably get easier to take. People working on a combination flu and COVID shot, so you just get one needle and 2 vaccines. I think making things easier for people over time will be the way to get more uptake. There are vaccine needle-free technologies already for people who have normal immune systems. You can take flu mist, which is another way of giving the vaccine. And there are also needle-free injectors now that are being developed. But nevertheless, COVID is going to probably settle down to, deaths that are higher than diabetes and kidney disease per year, and comparable to flu probably, and higher than pneumonia. One warning symptom that we've been seeing about, things down the pike that are coming is measles. So measles was eliminated in the US in 2000. But so far in 2024, we've had more than 125 cases of measles in at least 17 states. And last year, all of 2023, even as people were milling around, we had 58 cases, and it's just April, and we have more than 125 cases. In Europe, it's much worse. There are more than 30,000 cases. And that's because, all of this is driven by vaccine hesitancy. The measles vaccine is amazing. If you get 2 shots, which most kids get still in this country, you get 97% protection. 1 shot, 93% effective. Most of the measles we see in the US are people who've been abroad and then come back and then spread it to vulnerable people. Measles is one of these illnesses that, can cause a lot of people to get very sick. If anybody has had relatives who had measles in the 50s before the vaccine came out, they can attest to that. It can cause deaths, particularly in kids, and can cause, there's a long COVID version of measles too that can cause brain inflammation even up to 7 years after the measles. So again, prevention is going to be better than cure, but the big superpower of measles is how transmissible it is. Somebody can have measles, come into a room in a restaurant, leave the restaurant, and 2 hours later you go in the restaurant. And if you're vulnerable and haven't had a vaccine when you're a child, you can get measles with very high probability 2 hours later. If a person with measles comes in a room, more than 90% of people in the room who are not fully protected would get measles. So quite potent. The way to recognize measles is somebody who has high fever and a big rash, That's probably the easiest way to think about it. But again, before that, it looks kind of like the flu. Then you get this big rash. So one other pearl for you and your congregants is that people can also arm themselves with this information, because again, we haven't seen a lot of measles until recently, so people are not as well up to date on kind of recognizing some of these new illnesses, new old, that are coming back now in the face of fewer kids being vaccinated against measles. And we need everyone vaccinated, because there are going to be some people who are not going to respond to the vaccine, but we rely on the immunity of the group or the herd to protect the vulnerable people in the community. And then finally, in terms of disease X, it's really a placeholder that the WHO is bringing up very prominently now, which is a way for countries to get together to really strengthen the infrastructure to prepare ourselves for the next pandemic. Prevention is never exciting. It's always, people are always primed to treat something once you have it, but prevention is much cheaper than, curing something or experiencing the fallout of a pandemic. So we need to strengthen primary care, continue to have countries develop research and science and share. We need to spend more and spend smarter. And again, like I mentioned, prevention trumps treatment. In fact, only 3% of the budget is spent on prevention now in most countries, and we need to share data. It's likely that disease X, or the next pandemic, is going to be a respiratory virus spread by the air or droplets that is currently circulating in animals. One very big example of that right now is avian flu. It's crossing species right now. It's mainly, as the name suggests, avian flu, of influenza of birds. 4 of the last flu pandemics in the world, starting from the 1918 flu pandemic, started off as avian flu. And the reason why avian flu is a thing is because we haven't seen that kind of flu as humans before. So if it gets into us, it generally causes us to get very sick, just like COVID was new to our body's immune system, causes us to get very sick. And so far, it hasn't crossed species so that humans can transmit it to humans efficiently yet. But we are seeing it. First, it was just in birds. Then it started affecting seals and other mammals. And now it's affecting cows for the first time. We know that it affected chickens, and it brought up the price of eggs. So I think the writing is on the wall. It's not saying that we have to be scared. Right now, there's very low threat of avian flu to us. We have a stockpile of vaccines in the US, but it is a symptom of things that are going to come. And it's really up to us to really keep that mindset of curiosity, keep that mindset of openness, not to be afraid moving forward, and to continue to support each other. So one quote from Albert Camus is, there have been as many plagues as wars in history, yet always plagues and wars, both of them, take people equally by surprise. But we should not be surprised by the fact that we need to prepare. So for the final word, I spoke to Michael Liu, who's a dean of the School of Public Health at UC Berkeley, about his perspective on where we're going as a world.
COVID has shown us that we got big problems to solve in public health. We still got much of the world's population, including 80% of the population in Africa, that still need to get vaccinated. We've got a broken public health system here in this country and in many parts of the world that needs to get fixed. We got a decimated public health workforce from decades of underinvestment in public health that needs to get revitalized. And we got an antiquated public health information system that needs to get modernized. We got deeply entrenched institutionalized racism that underlies so much of health disparities in this country that needs to get dismantled. And we're fighting a losing battle against disinformation and misinformation that we need to get a lot smarter in fighting. And we really need to build a global early warning system for future pandemic before the next one strikes, which will require an unprecedented level of international cooperation at a time when the world is sinking into deeper and deeper nationalism and tribalism. So from a public health perspective, we got a lot of work to do. And if we don't figure out how to solve these big problems, any future COVID research would be like just putting a Band-Aid on a ruptured aortic aneurysm.
So sorry, this went a little bit longer than I thought, but thank you for your attention.
Dr. Chin-Hung, to say thank you is insufficient. The breadth of what you shared today and your candor as well, we are very, very grateful for. This presentation, recording link plus your slide deck will be sent out by day's end to our 5,600 e-subscribers. And I am going to encourage them to share it with their congregation leaders and others because it's important information. We did receive a number of detailed questions, which I am going to forward to you. And at your leisure, if you wouldn't mind getting back to these folk, I would just close with two quick questions, which I think would be appropriate. What lessons did you take from our response to COVID, and are we prepared for the next pandemic?
So the lessons are several. One is that, messaging is really important, like Greg Ligon said. Alignment of messaging. I think in San Francisco, we were lucky because public health, faith leaders, academic institutions, hospitals, the mayor's office, everyone was aligned. In other places, they weren't, and that really didn't serve them well. Number two, we learned that responding to social ills in the society, responding to structural racism is important because that affects health, apart from the other reasons to protest in the street. And I think what we did was we really went through a model of harm reduction in terms of saying, yes, during George Floyd, you should go and protest in the street because that is a public health response to a problem of health disparities. But here's how you can do it safer. Here's how law enforcement can do it safer. We learned that money is important, and we learned that we need to really do outreach in specific communities who have specific barriers to trust over time. So I think those are all things that we've learned during the pandemic. And I'm sorry, I forgot the second question.
Are we prepared for the next one?
I think we had a dress rehearsal during Mpox, formerly known as monkeypox, in the Bay Area. We did quite well with that. I think we're not prepared as a country or world, but in the Bay Area, we can't do it all alone. But if we put into lessons, because we had the lessons of HIV, now we have the lessons of COVID and Mpox, I think we at least have the playbook, but we can't do it alone. And, we really need sort of like federal and global, bringing down boundaries and more sharing.
I remember being with the mayor in the Grove and her saying that had it not been for the HIV epidemic, we would not have been prepared for COVID. And I believe that that's the case. Thank you for not only this presentation, but everything that you do. And please also thank our friends at UCSF Medical Center for making you available to be with our community today. We are very, very grateful. This brings to a close today's program. Please stay tuned for future programming. May God bless you and God keep you.